Just want to say thank you for taking the time on a Friday afternoon if you're watching this live. And if you are watching the recording, we just want to say thank you for taking the time to watch the recording whenever it works for you. Really excited to be able to share this information with the attendees. Still see some people joining. So once again, if you're joining now, this is the beginning of the Suicide Mortality Review Toolkit Key Strategies and Reflections webinar. We'll give it a few minutes before we get started. Very excited to see some familiar names. Glad that you're able to join us. Just to let you know that you will be able to communicate with the presenters through the question and answer pod. The chat function is not enabled for this webinar. So if you have questions, please submit them through the question and answer pod. It should be at the bottom of your screen where you can answer or you can submit questions, and our host, our moderator, will be monitoring the Q&A pod and will be answering the questions as we get going. So I see that we have a good number of attendees, and so at this time I will hand it over to our moderator, Andrea Lee. Andrea.
Thank you, Dwayne. Good afternoon, everyone. Thank you all so much for joining us, as Dwayne mentioned, on this Friday afternoon. Welcome if you're listening to the recording. A note, this webinar is being recorded, so please do keep that in mind. I'm Andrea Lee. I'm with VA's National Suicide Prevention Program, and I help to coordinate all of the mayor's and governor's challenge efforts across the country. We're so excited for this webinar where we are bringing together for the very first time all of our inaugural Suicide Mortality Review teams. So a big welcome. Really excited to have you all here today. I believe this is our first formal touch point with you all in this larger group. So can't wait to see some of you at our academy in a couple of months. But prior to that, really wanted to bring us together and have some level setting around the Suicide Mortality Review Committee Toolkit. Next slide, please. So our usual disclaimer: the views, opinions, and content expressed in this presentation do not necessarily reflect the views of SAMHSA, HHS, or VA. Next slide. As I mentioned before, we're really excited to be kicking off the Suicide Mortality Review process with you all. Before we jump into the objectives, just wanted to do a quick shout out to the teams that are here with us today. So welcome to the Suicide Mortality Review teams from Arizona, Los Angeles County, Maryland, New York, Ohio, and West Virginia. Really excited to have you all with us, and thank you all for being part of this effort. For today, we hope to provide an overview of the Suicide Mortality Review Committee Toolkit, where we have several key authors on the line with us here today. We're going to run through some examples of processes that you might find described in the toolkit from both a centralized and a decentralized perspective, and then talk about the key strategies for consideration that are outlined within each of those three stages. So you'll see that theme pop up a couple of times throughout the call. Next slide. We have three wonderful presenters here today, and because we are virtual, I could have had the option of reading these bios to you, but I will spare you all that. We have three very esteemed presenters with us. We'll first be hearing from Dr. Kimberly Repp, who is the Chief Epidemiologist for Washington County, Oregon. She's been with Washington County Public Health since 2011 and has been nationally recognized for her work in suicide prevention. She's also developed the Consolidated Risk Assessment Profile form, which you all will be hearing more about today and at later parts of this process. We'll next be hearing from Mr. Carl Roston, who is the Suicide Prevention Coordinator with the Montana Department of Public Health and Human Services. He's also a member of the Montana Governor's Challenge team. Mr. Roston has supported the integration of evidence-based programs to all Montana secondary schools, and also works to implement the state suicide prevention plan and support the Montana Suicide Prevention Lifeline. We'll then hear from Mr. Dwayne France, who many of you know already. He is the co-director of the Service Members, Veterans, and Their Families Technical Assistance Center and is a retired Army non-commissioned officer, combat veteran, and clinical mental health counselor. Prior to his current role, he served as Director of Veteran Services for a large privately owned outpatient behavioral health clinic. Next slide. And before we jump into Kim's slides, I just wanted to say again, thank you so much to the presenters. And a quick note about self-care for all of our attendees on the line. I know this is a long call. Please feel free to step away, take time you need. We also may be discussing some content that can be distressing, so please also feel free to step away if needed. And please reach out to any of the staff, either via Q&A or via email, whatever you need, and we'd be happy to assist you. So with that, I will turn things over to Dr. Kim Rep.
Hi, everybody. Hi, LA County, because I was just there last week. Good to see you all here. I want to also give a warning that because of impeccable timing, the Hillsborough air show is happening over my house right now with the Blue Angels. So if you hear jet noises in the background, I apologize. That's what that is. So today I want to talk a little bit about the suicide fatality review and, in my view, how it fits into the data iceberg that may represent all of the information available at a suicide. So at the top, you have your national surveillance data. So that's going to be like your suicide rates by state or at the country level even. The next level of information is the local death investigator data. And by that, I mean the person who went out and performed the death investigation on behalf of the jurisdiction. That individual gets all the information from law enforcement, medical records, et cetera. So it's a really robust source of information. Suicide fatality reviews are designed to discover the system level interventions to put in place to help protect others. And the deepest of the deep dives would be an individual psychological autopsy, which is usually done in conjunction with the family to determine why a suicide occurred. Next slide, please. So what's the difference between a suicide fatality review and a psychological autopsy? So a lot of people actually do both. So a suicide fatality review has multidisciplinary sources of information. In most states, not Carl's because he's awesome, but in many other states, it requires consent from the family to do, like share the information. The family and friends of the decedent are never, ever at the table for suicide fatality review. It's gone over in one meeting, and the purpose is very system level interventions. Like, how can we stop this from happening again for a person in similar circumstances? Where a psychological autopsy, though there's actually professional training you have to get to be able to perform that work. Of course, you know, it's usually at the family's request, which is consent. And psychological autopsies take a very long time. They can take months or a year, where the person performing the psychological autopsy will interview everyone they possibly can to get as much information. And the usual purpose of that is, why did this death happen? Next slide, please. When we started our suicide fatality review in Washington County, Oregon, as many of you know, we started with 3 people. We had like a medical legal death investigator, an epi, and someone who was interested in suicide prevention, but doesn't have the title of suicide prevention coordinator. And as we built our teams out over the years, these are some community members and programs that I recommend to have at your review because they bring really unique, helpful information. So definitely a death investigator, get your VA, public health, EMS, anybody that is part of a crisis team, anybody who basically works with imminently suicidal individuals as a part of their daily job. They're going to have a unique perspective for suicide fatality review. Crisis line, a NAMI representative. If you have a chaplain, and I know after talking to LA County and some other counties, The chaplain may sit in fire and they might be part of law enforcement or they might be independent, but essentially a person whose purpose is to provide comfort at the death scene to the family, sometimes with a spiritual or religious aspect. They're very important to have. And anybody who does inpatient psych holds is also very helpful to have at the table. And again, these are not required to start at all. It's down the line. Consider these people as you build your review up. Next slide, please. This matrix was developed by Idaho State University, and I have adapted it for what we use in our review. And like I said before, you're thinking about what are the changes in technologies, systems, laws, anything that you can possibly think of that would either minimize the risk factors or increase the protective factors for that person. Now, the most challenging aspect of this is we all have our biases of that's not possible, that'll never happen, there's too much political will against that, et cetera, et cetera. But the best recommendations that come out of this are when you kind of let those chains go and say, okay, if I had a magic wand, this is what I would do. And you'd be very surprised about what comes out from those thinking in that way versus the constraints in which we normally function. Next slide, please. Some of you have already heard about this, but we've had some pretty newsworthy occurrences from our suicide fatality review. The first one, we had a motel, excuse me, in Washington County that people were going to end their lives at. There was no connection between age, sex, race, and even means of how they were occurring, but for some reason, people just kept going to this particular motel. So after we obtained services for the housekeepers who repeatedly found the bodies, we trained the front desk staff in question, persuade, refer, which is for lay people like me, not for clinicians, to ask the question, are you thinking about killing yourself? And then calling a crisis line, staying with them until they have a safety plan. And it's very scary to ask somebody that and to hear them say yes. It's pretty terrifying the first few times. Well, after we trained the staff, it wasn't even, it was a month before a woman came in with no luggage and appeared very distressed. The front desk clerk said, are you thinking about killing yourself? And she's like, yeah, tonight. Here's my card. Like just completely nonchalantly. And the front desk staff said, do you mind if I get on the phone with the crisis line? She's like, okay. So got with the crisis line, they made a safety plan. She ended up was transported to the hospital, but she is still alive today. And she credits that front desk staff for asking the question. Another one is we had too many individuals that were dying by suicide immediately after being discharged from the emergency room. We all know this happens. And so we were able to provide our hospitals with data for the risk factors, essentially, of when that happens, like what's going on with that particular group of patients that could be different than others. And they were able to make policy changes based on their further psych holds and like who stays in the room, those kind of things that because we provided them with that information. Another thing, we were able to detect a cluster of youth suicides very quickly because of the scrap form that we were talking about that the death investigators fill out after the death. It's real-time information. So if we would have waited for vital stats to hear back, it would have been 2-3 weeks after. But because the death investigators were entering this, we have between 0 and 5 in a year, and we had 3 in a week. They were not related at all, but because we had this system, we were able to detect it and get post-vention teams on site very quickly. And the final big one that we discovered was the people who were being evicted from their homes were dying by suicide. Now, my county has a very, very low eviction rate, but obviously it's a big deal if someone loses their home. So I went to the sheriff's office because being evicted is a legal procedure and you are served with documents. And the sheriff's office does that for Washington County. I said, you know, can we put some crisis line information in there? And he's like, you know what, I'm going to do better than that. And for every eviction notice that's served in Washington County, they bring a member of the mental health crisis response team who is a trained clinician to be with that person at that moment where they're receiving the eviction paperwork. And sure enough, within a year and a half, eviction dropped off our radar as a risk factor showing up in our suicides. And all of these little findings were in part through Suicide Fatality Review. So if you trust your data and just follow the trail, whether it leads you to a motel or an eviction, or just trust your data and follow it, and that will tell you where you need to go. Next slide, please. The lessons that I've learned from doing this across the country is, in time, once your review is stabilized, the more perspectives you have at the table, the stronger your recommendations will be. So it's always good to consider as many voices as is comfortable for your review. People have very different coping mechanisms. So again, I'm coming from a medical examiner background. They do this stuff all day, every day, law enforcement too. And then you have your trauma-informed individuals and your clinicians, and trying to make them both happy and trauma-informed is near impossible. So recognize that maybe law enforcement and death investigators in certain aspects of this community are not going to prefer to engage in what we would call trauma-informed care. And it's important to give them an out while still keeping the trauma-informed care for everybody else who wants to stay. I usually do this with everybody, but practice at least once with a small group before you do it for real the first time with your entire team. The most important thing is to have a feedback loop. So all your suicide fatality review people need to know these are where the recommendations are going, and this is the action that's taking, and have that feedback loop. It's very important. And remember, data takes time. So even though you might be doing a suicide fatality review in 2 months and you might have 5 cases, you can't change the entire system with 5 cases of data. You need to get a little bit more. So it's important to be patient before you take a lot of action. But again, it will, if you wait and you collect your data, you will get the information you need. Next slide. And I always end with this one because this work is very, very, very challenging. And sometimes I want to quit, and it's hard. It's very hard. It's very traumatizing. And so I keep this quote up that if we don't work on it, it's not going to get done, AKA never grow a wishbone where your backbone ought to be. Thank you. Next slide.
Thanks so much, Kim. I think, again, I've heard you speak so many times. I learn something new each time. So thank you so much for those very moving examples. And then also, again, the reminders around self-care. And I think that the piece about the data and being patient is a very important one as well, because we know many folks are at the table because of the 2-year lag in the current data systems. And so folks are like, okay, how can we get data faster? But even given that, there's still some level of patience that would be needed going through this process. So thank you so much, Kim. With that, just a quick reminder for folks, if you have questions, please do feel free to enter them in the Q&A. And also just wanted to acknowledge that the slides and recording will be sent to all attendees after this call. Without further ado, I will turn things over to Carl. Thanks so much, Carl.
All right, thank you so much. So I'm going to talk a little bit about more of a centralized process that we used in Montana. And in our program, we review all suicides. Any suicide that has been ruled or death has been ruled a suicide, we review. And really, this started. I've been in this position as a suicide prevention coordinator for 15 years. And it really started in 2012 when I was working with a psychiatrist, and we were taking a look at programs, evidence-based programs. And we realized that a lot of these programs weren't a good fit for Montana. A lot of them were developed on the East Coast. A lot of them were developed in urban settings, which is exactly opposite of what we have in Montana. And so we really didn't know what was happening in Montana specifically. We wanted to better understand the factors specific to Montana. And that's where we decided that the best way to do this was to work with our legislature. And if you would advance the next slide, please. So we decided that because of the confidentiality issues and all the stigma, especially in our state, around disclosure and around identifying, that a legislative action was really necessary. And so we worked with a local legislator and submitted or got a bill, HB 583 passed, that created a suicide mortality review team. And it basically allowed us to have access to confidential health records, mental health records, school records, just about any information that we had. And the team consisted of myself. We had a psychiatrist, a psychologist. We had an LCSW who also worked for the VA. We had a law enforcement official who was a county coroner. We had a tribal representative. And then we had a community representative that happened to be a chaplain, but also was a survivor. She had lost her son to suicide. And next slide, please. And we met. We would meet and at least every quarter, and we would review all the suicides that occurred during that quarter. And the way it would work is that every week I would get death certificates from our vital statistics. And I'll tell you the reason our program worked is because of collaboration. I mean, the legislation was critical, but we had so much collaboration. Our vital statistics folks actually modified death certificates to give us more information. And so we were able to collect just from a death certificate about 18 to 20 different data points. So we would get a death certificate, and then I would send a request to the coroner for additional information. We would put down the coroner's reports. A lot of times coroners would send videos of the crime scene or what the police walked in on. We would get medical records. We could request information from primary care, mental health, schools. We would get information on social media, criminal backgrounds. Pretty much everything that we could find, and we would accumulate all this information, and we would review every one of those suicides as a team. And what we really were looking at is identifying the factors that led to the suicide. We wanted to see what happened to this particular person, and then we identified what could have been done to prevent this suicide. Now, when we reported out, we summarized everything. We never talked about individual suicides. Everything was a summary. Now, next slide, please. The nice thing in Montana is that death certificates are required to be submitted within 10 days of a death. And so we were probably getting as close to real-time data as that we could ask for. Everything went through me. I maintained all confidentiality. The thing that's unique about this is that when we started this, there was nobody else to model this after. We were the first state to take a look at this. And in my research, what I found is there was one province, Manitoba up in Canada, University of Manitoba, did a 1-year suicide mortality review a few years prior. And they had a manual that they wrote, and I contacted them. They allowed me to, they said, oh, please use anything that you wanted. But then also a major one that we modeled our book was off of was the Fetal Infant Child Mortality Maternal Review, which is a national thing. And I'm part of that team in our state. There are national guidelines around confidentiality and forms. And so we really borrowed a lot of our stuff from the existing FICMR national standards, which really made this a much smoother process to go through. Next slide, please. So as I mentioned, though, we needed to start to gather more information than that was typically available in a coroner's report. So once I received all the material and I would go through it, we would send out a request for additional information where we were asking about medical history, mental health problems, substance abuse. So we also worked it out where we were able to get toxicology reports from the state crime lab. We asked about relational issues, financial issues, criminal issues, everything that we could. And next slide, please. And just to kind of give you an idea, this is what that form looked like. I know you can't really see it, but it really wasn't much. It was 2 pages. We wanted to make it easy for the coroners because otherwise they wouldn't do it. Next slide, please. So we would review, and we created a summary report. And the important thing that I want to emphasize with this is that this has had long-term benefits in our state. We came up with a number of recommendations. For instance, we knew that we needed to continue this process of reviewing death certificates. It gave us some insight into working with our tribal systems, the university system. Also, though, we started to work with the VA very closely, because what we found is that when we would take a look at numbers through the VA had fewer suicides than what I had for veterans. And so we got a number of MOUs in place where I was able to share our data so that the VA could take a look at the suicides that I was getting that they were missing. And some of them, of course, there were many that maybe the person was in the armed forces but wasn't a veteran. Or what was most common is that it was an older vet that didn't have a lot of contact with the VA, so the VA didn't really know about it. But we were able to share that data so that the VA could provide services to the family. So that was one critical piece. Next slide, please. Another thing, and this is where we really started to notice factors that stood out in Montana, at least, is that with our youth suicides, we were finding that there was a consistent message that these were kids that had limited coping skills, low resiliency, not able to deal with adversity, social issues. And so it drove us to start taking a look at programs that focus on early interventions with kids. And one that we started in our state was called the PACS Good Behavior Game, which teaches 1st and 2nd graders coping and resiliency skills. And the data that we received out of our review drove our ability to get funding to start providing this in elementary schools around the state. Another key piece, and especially for rural Montana, we will never have enough mental health. You have to remember, it's a massive state. I mean, if you go from one corner to another, it's 750 miles, and yet we have barely 1 million people. And so people are spread out. There's lots of silos. And we are never going to have enough mental health, but we do have primary care. And so really it pushed us. We were seeing that many of these people that died by suicide had seen a primary care provider within a month or 2 of their death, or they had other health issues that put them at risk. And so that really pushed us to start to train in zero suicide and suicide safe care in all of our clinics and hospitals around the state. But it also prompted us to implement it in the schools of nursing, the physician assistance program, or at Rocky Mountain College. We started training with the Montana Medical Association, the Montana Nurses Association, schools of social work, counseling, pharmacy. We started to train pharmacists in suicide safe care. And also, of course, we have a large American Indian population. And we really needed to have someone who specialized with that population. And although we weren't able to add an official position, what we did do was we were able to get a zero suicide grant through SAMHSA for tribal health. And that allowed us to hire a tribal member who still is with us. And he focuses specifically on tribal health, but also with the reservations around the state. Next slide, please. Of course, firearm safety and lethal means counseling is a predominant thing. In Montana, 86% of all firearm deaths are suicides. I think that's the 2nd highest in the country. And about 63% of all of our suicides are by firearm. It's about the same for kids too. It's 62 or 63%. And so we started able to focus on safe storage. We started to work with pediatricians, giving out gun locks. We started to really push the CALM program through SPRC as far as training providers on how to do lethal means counseling and taking a look at elements that might be more specific to Montana. So for instance, the number of firearms in a home. I mean, we had suicides in our state where there are 30 or 40 firearms in the home. We have had a number of people who used an antique rifle on a mantle. So these are things that many people don't often think about. We were starting to be able to take a look at and train people to look for these things. Another major thing is early intervention. We know the best prognosis, that early identification has the best prognosis. And so we were starting to see a lot of mental health issues that were starting in late elementary or middle school. And we needed to identify and start screening these kids. And so we were able to work with a group out of Livingston, Montana, that started to screen in schools. And we have been funding this for about 3 years now. And they are screening about 25 to 30,000 kids a year. And it's screened for depression, anxiety, substance abuse, resiliency, suicide. And the unique thing about this, we can't do this if we weren't able to offer them help immediately. So when a kid takes this screen, it's a computerized screen. The minute anything high risk comes up, they are immediately connected with either a school-based mental health provider or telehealth, and they're required to have services within an hour of the screen. And so this is something that we're continuing to do as well. Next screen, or next slide, please. The other big thing that I think has been neglected are people that have lost someone to suicide. We know that a survivor of suicide is 3 times the risk of suicide themselves. We know that there's about 135 people that are exposed to every suicide, and somewhere between 6 to 11 people are considered survivors. What we also know is that the average survivor does not get any help for at least a year following the death. Our review allowed us to start to provide resources immediately. So on our death certificates, when with next of kin is identified, we immediately sent out resources, survivor resources, to every next of kin on every suicide, so that they were getting resources 2 to 3 weeks after the death, not a year. And we send them out no matter where they are. Last month, I sent one to Bosnia. So we send them out no matter where the survivor is. We want them to have resources. Next slide, please. Lasting effects, and this is the part that's been really beneficial. Every legislative session since 2013, every suicide legislative bill has been based on our findings, including our session that just ended. And we are able to continue to build. So for now, we now have a bill that was just passed that's going to require toxicology reports for every single suicide, and also just to take a look at, cross-check them with the prescription drug registry, so that we can start to better understand what's going on with folks that die by suicide. Also, it was a major catalyst for us to become part of the CDC's National Violent Death Reporting System. For whatever reason, Montana held out on that. They did not want to be part of that. Our review, the robustness of our data really pushed us to say, hey, we need this now. So we finally became one of the last states to become part of the MVDRS. And because of our work that we laid with epidemiologists and our vital stats, we hit the floor running. I mean, we're ahead of the game in so many ways compared to what the CDC asks. And it's because we are already doing something like this for a number of years. Also, it gave us an opportunity to better train coroners. I'm on the faculty of the Montana Law Enforcement Academy, so I would go in and train coroners. And it also served as a way of starting to perform more psychological autopsies, or at least increase awareness around the psychological issues. Next slide, please. And that is it. And with that, I'll hand it back over to Andrea.
Thanks so much, Carl. Such great information, and really, really inspiring impacts that you all have done in Montana. We had a couple of questions come in, and I'm happy to take those briefly before we dive into the toolkit session of the webinar. So, Carl, just to clarify, is Montana doing suicide fatality review for the entire state, or is this being done at the local community level?
Sorry, I had my mute on for a second. Yes, we do all of them. And so the way it works, and actually we have almost a check and balance piece, because our violent death reporting system now has a task force. I'm part of that task force, and I now have the luxury of having a few epidemiologists. I was an epidemiologist, and I'm not qualified to be one, but I used to do it. And now we have a team. We actually have resources from the CDC, and we review every single one. But I also get all the death certificates every Friday, and I make sure that I'm collecting data points on counties and age and all those factors, and also getting resources out to survivors. But also, I'm also now many of our counties have their own FICMR teams. And anytime that there is a youth suicide, I join that team for their review to provide resources. So we're also doing it with we have a domestic violence fatality review. We have an American Indian mortality review. And so any of them that involve suicide, we take a look at, or I join. So yeah, we're doing it statewide for everybody.
Thanks so much, Carl. Yeah, really, really interesting network and partnerships and connections that you all have in Montana. And then another question that came in that I think we'll start to touch on this in the next section of the webinar, but would love to get both Kim and Carl, both of your thoughts on this very key question. That just left my, okay, what tends to be the most difficult barrier to starting a suicide mortality review team?
Kim, go ahead first.
Okay, so for the way I do it and have taught it, it's the voluntary engagement by either your coroner's office or the medical examiner's office, because they are in my opinion, one of the absolute key sources of information, at least in Oregon by law. Our investigators are required to have reports for anybody who touches foot on the scene. So they keep all the information. And as us former EPIs know, garbage in, garbage out. And when you force someone to do a form they don't want to do, you get garbage data. So it's really important to have buy-in voluntarily from that side of the house to ensure your data are solid. Carl?
And actually very similar to what Kim was saying, that buy-in, but we had to get it from a statewide level because Montana has that cowboy mentality. We don't like to talk about our problems. Everyone's pretty independent, and so we would get a lot. If it wasn't for the legislation, we would never have gone anywhere. And I can't emphasize that enough. And surprisingly though, once that legislation was there, I was amazed how easy it was to get stuff when it opened up doors. We were able to get collaboration. We started to train coroners early on, because that was one of the big barriers that in Montana, there's not a lot of standards concerning coroners. And I would literally get yes, no answers from one coroner, and the coroner in the next county would send me an inch file and movies or videos of everything that went on. And so there really, it took us about a year working with the academy to get post credits for coroners. So that was there was an initiative and training to get that buy-in from them. But once we did, it was amazing how really easy this was. I know a lot of people don't think it could be easy, but of course, I also am only dealing with about 300 to 350 suicides a year, which makes it a little easier, but it's has been very manageable.
Thank you both so much. I think we're now we're getting a lot of great questions in the chat. I think some of them are starting to dip into the toolkit side of things. So please continue to keep those questions coming in. We hope that some will be addressed as we go through the next couple of slides. And if not, I'll make sure to come back to those as well. So over to Dwayne to talk us through some key strategies. You'll see a theme coming up in the next set of slides around some considerations to think of as you are going through developing a suicide mortality review committee. So over to you, Dwayne.
Thank you very much, Andrea. As everyone who is participating in our suicide mortality review process through the Technical Assistance Center We have been partnering with SAMHSA and the VA to develop this effort along with key input from subject matter experts like Mr. Rust and Dr. Rep. And so many of you, I hope, would have seen or received a copy of the Promising Practices for Suicide Mortality Reviews Committee Toolkit. If you have not gotten one and you would like one, we are dropping the email. You can request it via email, smvftaCenter@prainc.com. It is available upon request at this point. But the toolkit itself is broken up into 3 separate sections. So section 1 for the exploratory stage, for those cities, states, communities, territories that are initially considering whether or not they should or how they want to create a committee. Section 2, the implementation stage, if you've decided you do want to have one or that there is a need for one, how do you initially put the steps in to establish that? And then finally, sustainability, if there is an existing one, how can you expand upon or improve the current efforts? And so this toolkit is really more of a conceptual guide to get you started. There are some elements such as Carl mentioned Montana's legislation that is included in the toolkit, draft legislation, the scrap tool, and other different portions that Dr. Rep, those things are in the toolkit. But we would just like to take the next few minutes to talk about some of these elements. So first, the exploratory stage. If you're considering establishing a Suicide Mortality Review Committee, it can be a little challenging to know where to start. It may be better to have a broad review where you're not really focusing on service members, veterans, and their families, or a different population such as youth or the elderly. Or with other communities, it might be necessary to start with a particular population and then expand to larger efforts. This section offers 5 key considerations, and we'll talk about those in a minute, to think about when you're first considering establishing these efforts. The second session is, if you do feel like you need to have one, really establishing clear goals and intentions for the committee during the development. The structure of the committee is important for longevity. That's the key, is the structure, how you build the committee, the charter of the committee, who does what, just the nuts and bolts, the logistics of the committee, as well as the actual work of the committee. So this section really kind of starts to dive into some of those information. And then finally, if there is efforts going on, as Carl had mentioned, the fetal and infant mortality review or other reviews, or some of you have these general community reviews, but then want to specifically focus on a population such as service members, veterans, and their families, this section really dives into what those might be. So what we'd like to do is give you the 5 key strategies. There's actually a lot more information. There's some insights from the field. There's some key things to be able to consider. What we'll do is I'll go through each of these briefly, and then Carl and Kim will be able to provide their insight, a little bit of behind the scenes on some of these topics. So if you're looking at the exploratory stage, these are the 5 key considerations that are in the toolkit. So first is identifying and analyze your local suicide data. Then identifying the current suicide prevention efforts in your community. What is your local death investigation infrastructure? What are your potential partners to include when you're developing or planning the committee? And then really what is critical is finding an organization that has the capacity to be the backbone organization. In this collective impact model, someone needs to own this effort within your community. So very briefly, as we, and Kim had talked before, you have that national data. It's really important to understand, identify, and analyze your local suicide data. So the VA obviously has state level veteran suicide data for veterans, but also the web-based inquiry statistics query and reporting system, or WISCRS, is a very important place for you to be able to get that data for your community. And of course, the National Violent Death Reporting System, all 50 states, Guam and Puerto Rico currently have someone who is their NVDRS program manager. And so the NVDRS program on the CDC's website has lists for your state's program manager. So that's someone else who could definitely provide you with the fact of what is the situation, at least in your state, if not in your community for large communities. Second is identifying current suicide prevention efforts in your community. This is not suicide analysis. This isn't, these are groups that are doing things to reduce suicide in your community. On the far left, you'll see obviously VA SAMHSA's Governor's Challenge at the state level and territory level, and then the Mayor's Challenge in specific communities around the country. Those are coalitions that are actually implementing programs to reduce suicide. Many states, most states across the country have coalitions to address suicide prevention. Things like the Suicide Prevention Coalition of Colorado, Arizona Suicide Prevention Coalition, Ohio Suicide Prevention Foundation. There's a state organization that is addressing suicide prevention. And then, of course, many people are familiar with the American Foundation for Suicide Prevention. One thing that Dr. Rep often says is, if you generate recommendations based off of these risks, you have to have somebody to hand it off to. There has to be an organization that has the capacity to develop and implement programs. That's not specifically the role of the Suicide Mortality Review Team. So it is necessary, as you're doing this, is to identify current suicide prevention efforts. It is also, as both Kim and Carl mentioned, critical to be able to identify your death investigation infrastructure. Across the country, the laws are very different. They vary from state to state. You either have a coroner model or a medical examiner model, or combined. You either have a county-based decentralized model or a statewide centralized model for death investigation. Again, either coroner or death investigator. And so it's necessary for you and your efforts to find out what your death investigation infrastructure looks like. So the CDC has this listed for each state, all of the state death investigation laws, and we will include these links in follow-ups as well. But you will be able to go to the CDC and find out what your specific state's death investigation infrastructure is. The next is, of course, identifying potential partners to include in planning and development. So Kim talked a little bit about that related to, who are the initial partners. So public, private, or nonprofit organizations, governmental organizations, city, county, and state, territory, or tribe. Organizations with a focus on mental health, maybe not suicide prevention specifically, but more mental health broadly. So those are the ones that people typically think that would be partners. But then you also have partners that may be necessary when you're addressing a particular population, such as youth and young adults, schools, colleges, local parent groups. If you're really looking at the military and veteran population, veteran serving organizations. Or if you're looking at industry specific groups, such as agriculture or construction, find your local organizations that are sponsoring or focusing on those different groups. So your home builders associations or your realtor associations, or perhaps your restaurant and bar associations, if your community identifies a large number of the service workers dying by suicide. So again, really important to start to consider both inside the box and outside the box, who partners may be able to partner with you to plan and develop this effort. And then finally, it is critical to have an organization that owns this, right? So the collective impact model, find a backbone organization that can convene people, manage the meetings, be able to collect the data. As Carl mentioned, he is the person in Montana who collects the data. And so Carl is the backbone organization for Montana. Carl's office is the backbone organization. But really these backbone functions is really what we all understand with the collective impact model, guiding the vision and strategy, the aligned activities, shared measurement practices, building public will, that buy-in piece. It's very hard if there's not an organization that is doing this specifically. So that's the fifth thing that we recommend when you're considering developing a suicide mortality review committee, that to take these 5 points in mind. So at this time, I'd like to offer Carl first, and then Kim. Any thoughts on these 5 key considerations for someone when they're starting to consider to develop a mortality review process?
Okay, yeah, thanks, Dwayne. So I think something that Dwayne mentioned that has been critical in our state is working with organizations like NAMI and AFSP. We work very closely with AFSP, and we actually co-sponsor our state suicide prevention conference every year. And so it's a joint activity, but it also, the nice thing about this also, through our data review, if we find pockets of suicide, we can work with AFSP to get community awareness in those high-risk areas, whether it's an out of darkness walk. Mentioning the WISCARs is important when you start to take a look at, you want to start to have an idea of your trend data. And WISCARs is a great one as far as taking a look at trend data over years. My only concern with WISCARs is that it's not real-time data. Even as of this morning, they're still only at 2020 for their suicide data. So that also helps. The WISCARs does though help me understand, well, how does Montana look compared to Wyoming or Idaho, that type of thing. Also, when you take a look at as far as your local death investigation infrastructure, in Montana, it's law enforcement. We don't have medical examiners. 90, I think out of the 93 coroners we have in our state, 2 are medical examiners. They're for the larger cities. The rest are deputy sheriffs. And in 2 counties, it's the funeral home director. So really gearing the training. For instance, when we brought in a national trainer from AAS to do around psychological autopsies, we had to make sure we used the one that had to do with law enforcement, not medical examiners, because the one for medical examiners, they'd be talking over most of their heads. We had to gear it toward that. And then finally, one thing that Dwayne mentioned, taking, for instance, occupations, we really started to take a look at. In Montana, it's construction workers. And so when we started to see this, we reached out to the Montana Contractors Association and started to provide training to contractors around the state. Or in our state, we have a lot with farmers and agriculture. So we started working with promotions and media around with the Department of Agriculture. But it really allowed us to reach out to certain sub areas, even labor. It's really hard to hit middle-aged white guys. I mean, they are in school, they don't go to the doctor, but they work. So we worked with the Department of Labor, and they have this thing called Safety Fest, which are conferences around the state to lower worker comp claims. We were able to put in suicide prevention into those conferences. And we wouldn't be able to do that if we didn't have the data to support it. And with that, I'll hand it off to Kimberly.
Thanks, Carl and Dwayne. One political consideration that was a little bit surprising to us was around number 5, the organization who is the backbone. We had a lot of conversation about this. Community members were not interested if law enforcement was the backbone. We heard that very loud and clear. We use public health because we're essentially viewed as neutral within death investigation. We don't necessarily, we just want to help. It was not a threatening political bias to anyone. So that's also something to consider, is you, at the end of the day, unless you're Carl, you have to get consent from other people to participate, right? And if they will consider who that letter comes from. I guarantee you, whether it's the medical legal death investigator that sends the consent letter, or nobody opens letters from public health. That's okay. I'm in public health. I know that, but they do open things from death investigators and official government organizations. So really put a lot of thought into who politically what would be best for the community, for the optics essentially, for who to hold the review.
Thanks so much for providing those reflections. Did want to also weave in a couple of the questions that we've gotten in through Q&A so far. So for both of our presenters today, around how does the privacy and confidentiality piece with various different agencies impact data sharing? Or how should we manage the privacy and confidentiality piece in studying the deaths? So any insights you might be able to share would be great.
Well, I can start. I think that is where the legislation came in because it made the data allowed and for me to be able to share information. But we had to be very careful about how we were protecting the information. No individual suicide could be reported. Everything was a summary as far as went out. So really protected, because families wanted that, but also communities wanted that, to know that information was protected. And it wasn't until about a year into our process where we started to develop some trust. And then it opened the door. Then people would offer. I mean, I would start getting more information once they had a sense that they could trust me, that I was going to protect and value that data.
Thanks, Carl.
Agreed, definitely, Carl. So legislation was not an option for my elected officials at this point. So that is why we developed the consent form. It is held up across multiple states. California has the trickiest, I can hear all the Californians laughing, the trickiest laws around data sharing that I've experienced. And Humboldt County, California has developed a form that has passed through their legal, because not only does it have to give permission for you to share, everybody at that table has to take that form back to their lawyers and make sure their lawyers agree that it gives consent. So it took 2 years to develop that form. But again, now that it's developed and it's been used in a lot of jurisdictions, we certainly have something strong for you to start off with if you are not able to do legislation.
Thank you so much, Dr. F and Carl. And I think just to point out too, I hope I'm not stealing your thunder, Dwayne, but there are in the toolkit, in the appendices, there are several of the confidentiality forms. And the beauty again of this process, as Dr. Rett mentioned, is that we are more than happy to share some of these existing tools that have been developed across the country with you all. So I know we have a couple more questions, but let's move on to the next section here, and we'll try to weave those in as we go through.
Thank you very much, Andrea. And so again, now we're at the implementation stage. You've decided that your community, state, tribe, territory does warrant this. You have the will, you have the partners. So how can you get started? And so first, partnering with your local death investigation system, identifying a population of focus for review, consider existing reviews, establishing your group structure, and then really very important for many of us individually, and I think all of us collectively here presenting, is developing policies and procedures to ensure safety and wellness. So first, again, and you heard it both from Carl and Kim, that partnering with your death investigation system is critical. The work that we're doing as far as the suicide mortality review process is really designed to help states, territories, communities, tribes to be able to develop this process. We're not necessarily trying to solve the problem of proper death investigations, making sure that death investigation is conducted in a significant way. But this is a critical aspect to the mortality review process, is a strong partnership with the jurisdiction death investigation system. We use that term broadly. Again, it could mean coroners, it could mean medical examiners. Again, as an example, here in Colorado, I know in one of our southern communities, the coroner is also the pharmacist at Walmart. So if you catch him on one day of the week, he's in one job, and on the other day of the week, he's in a different job. And so it's very necessary that the death investigation office perform robust death investigations, but also there's some particular elements, the Suicide Consolidated Risk Assessment Profile, the SCRAP form that Kim mentioned, that if the death investigation office has the ability to just fill out this 5-minute form that answers questions that aren't necessarily part of a standard death investigation or are part of the worksheet for a death certificate. But it's really important, and you can see some of this, things like school stress, financial stress, individuals either a perpetrator or a victim of violence within a period of time. So these are things that really help you as a review committee to identify risk factors that can then be addressed. Second is identifying a population of focus for review. Again, you heard with Carl, that they do all of the reviews. Again, same thing in Washington County, Oregon. It's reviewing all suicide deaths. Our colleague Cicely from VA likes to say, even though that this is a SAMHSA-led initiative through the SMVF TA Center, partnering with the Department of Veterans Affairs, we want teams to be inclusive of service members, veterans, and families, but not exclusive to service members, veterans, and their families, unless that is a choice that you want to do. So this is not just do this review for military and veterans. If the number of deaths in a jurisdiction meets a minimum review criteria, about 30 within a given period of time, it's best to begin with a review of suicide deaths of all population groups. That may be, for example, as Carl said, there may not be an individual community within your state territory that reaches that level. Well, it's better to do a decentralized, or you may have a large urban community that would be better to do that with a centralized. If there is such a large number and maybe an overwhelming number of suicide deaths, maybe it is important to say we're going to focus this on youth and young adult suicide, or older adult suicide, or suicide in the military, veteran, or the first responder, or any other kind of designation that you're able to identify. Really these at-risk populations, and in many ways, all populations are at risk. But it is necessary for when you start out, you say, we're going to do this review for a particular population. And Carl mentioned this before, consider existing suicide or death review processes to develop your Suicide Mortality Review Committee. So the National Center for Fatality Review and Prevention has a toolkit. They have the standards for child death reviews and the fetal and infant mortality review. As Carl mentioned, they use that as a template for their reviews. So what other reviews in most communities in states across the country have legislatively mandated child death reviews? Now, there are portions of that that are not applicable to suicide, and we can have those conversations as what the differences may be. But it can be very, very beneficial is what are the processes that those teams are using that you can then apply to adapt to your efforts. And of course, when you start something out, what is the structure? Better to have a structure to start out with and adapt it rather than come up with a structure as you're developing it. And so again, as Andrea had mentioned, there's appendices in the toolkit that has some examples of different ways that you can do these kind of things. So when will your group meet and with what frequency? What documents are necessary? Who will be responsible for the logistics? What is your committee makeup? There's core planning group members. So who are the core members that are planning this? But then you also have ad hoc committee members. Kim has mentioned before about how having a wide range of spiritual and religious leaders, so that if there is a particular death related to that denomination, that you're able to reach out to that spiritual leader if they're Seventh-day Adventist, or if they are Baptist, or if they are Jewish, that you're able to engage with those leaders. They're not at every time at your table, but you're able to get their insight on particular cultural considerations for those. And so considering what your committee makeup can be is very necessary. And then finally, in this last one is Kim mentioned, and we all mentioned that this is hard work, this is difficult work, and it requires reflection on awareness of the difficulty of the task. The people who are reviewing these cases will be exposed to some very significant, distressing, graphic, and challenging information that especially those of us in the clinical field or the medical field, or as Kim mentioned, law enforcement or the medical examiner, you're exposed to this over and over again, and that can tend to take a toll. So it's very critical that you ensure that you build this using trauma-informed approach to support the mental health and wellness of your committee members. Ensure that your committee members include those who are trained in some sort of supportive care. Ensure that new members are informed about the exposure before it occurs, and then very carefully consider potential committee members who have lived experience with suicide loss. And so those individuals who have experienced suicide loss, there are some that have experienced this, some of you that I recognize as our friends here in the audience, who have done a lot of really strong work around their grief around their loss, and they're able to give a very good perspective of lived experience. The one thing that Kim has mentioned and that I absolutely agree, be very careful, even to the point of exclusion, for individuals who are attempt survivors to be exposed to these case studies, because we don't want to re-traumatize people. That doesn't mean that attempt survivors do not have a role in this. They can be advisory, they can be part of your outward facing group, they can be part of organizations that are implementing these things. But really there is a measure and a potential for re-traumatization for those individuals in this. So it's really, really important that you consider wellness of your committee members as you build this out, in first, last, and always considering that. And so at this time, I would like to offer Kim the opportunity to provide some reflections on these 5 key considerations, and then Carl.
Well, Dwayne, thank you. You covered most of it, I would say. I think I just want to reinforce about the suicide survivors and attempt survivors. We in Washington County, we tried 3 separate times to have a survivor join our suicide fatality review. And after the 3rd time of them leaving within 5 minutes, we decided that was just, it just was not appropriate to bring someone in. As much as you can, of course, again, incorporated that voice in other ways, but this stuff is, I mean, honestly, I've gone to hundreds of death scenes, and sometimes reading the reports is worse. So it can be really activating. So really watch for signs of people in distress. What I saw, and again, I'm not a clinician, but what I saw in my group was when people started focusing on minutia, such as why was he wearing a green shirt, things that didn't matter, like as a coping mechanism. So that can happen to anyone at the table. So just be really aware of body language and potential stress responses for those sitting at the table. Carl?
The one that I would want to emphasize is number 3, around consider existing suicide or death review processes. Don't recreate the wheel here. You have the Center for Fatality Review and Prevention has national guidelines, has the forms, has all of it. They've already gone through the hard part of taking a look at all the laws and everything. Don't recreate the wheel. You don't need to. There's a lot of good stuff that they have that would be applicable to your individual states. The only other thing concerning, kind of to build on as far as the scene and everything, this also got us to start forming loss teams in our state, where we're actually working with people that have lost someone, or advocates who go in with the coroner to immediately connect with the family, and that seems to work much better as far as decompressing or de-escalating the situation. So I think that's just another opportunity at the county level to work with your local county, your coroners and stuff, is to have things like loss teams.
Thank you very much, Carl. And to both of those points, I dropped in the chat the National Center for Fatality Review and Prevention. There is a link. We are also working with our friends at the National Center for Fatality Review and Prevention to actually have a present at the Academy in July, to be able to provide their expertise. And as Carl also mentioned, the local outreach to suicide loss survivors, the loss teams, we're going to be talking about that and postvention also at the Academy. So didn't slip Carl $20 to be able to plug both of those, but I'll Venmo him probably. Not that I know what that is. But that's very critical, both of those pieces, and those are definitely things that we're going to be addressing at the Academy. Andrea, I don't know that we have questions at this point, or continue on.
Yeah, maybe we continue on and then see if we have time to kind of revisit some of those.
Thank you. So the last stage that you see in the toolkit, and again, there's much more in the toolkit. There's some case studies, there's some lived experience or learned lessons learned from the communities. But this last is a sustainability stage. So we do know that there are some teams, some individuals who are attending this who already have these types of things in focus. So then what do you do to improve on or expand your efforts? And so Constant improvement, process improvement, reviewing goals, documentation, procedures, reviewing your committee membership, considering additional analysis methods, expanding review efforts to different populations if you started generally, or even different fatality types. And then deliberately focusing on reporting conclusions and making actionable recommendations. So again, here we are, the National Center for Fatality Review and Prevention. Some communities have already implemented mortality reviews for other methods or manner of death. Again, some of these are more punitive in nature or more involved with, say, the criminal legal system, looking for fault. That's not what we're trying to do with suicide mortality. We're not trying to identify who was at fault and who missed the gap. It was, how can we prevent another death such as this from occurring again? But the structure around the fatality review process can be very similar and can be easily changed. So again, we will link, as Carl mentioned, there is a manual, and our friends at the Center for Fatality Review, like I still have it literally on my desk and there's coffee stains. But using this structure can be very beneficial because you know how you apply things differently to your jurisdiction. But there is tools out there, as Carl had mentioned. And then reviewing your committee membership. So if there are committees, take a look at your committee membership. As Kim mentioned, they started out with a small number and then they grew and then they grew and then they grew. And you may find organizations that say, yes, I want to be a part of this. And then they're in that. And then they're like, well, I don't really have a role in this. And so you may have individuals that move in and out of the committee process. Or you may have individuals say, I want to be a part of this, but realize that maybe they're better as an ad hoc member. Maybe you only work with the local parent group if there is suicide deaths for youth or young adult, or your local LGBTQ plus advocacy program if it is identified as the suicide death is related to the LGBTQ plus community. And so really taking an idea of what your committee membership looks like. It's also important to explore how committee members experience the process as it relates to the frequency of the meetings, the workload of the meetings. So if you only meet once a quarter, but you do 10, 15 cases at a time, that can be as heavy as a monthly meeting with 2 cases at a time, right? So really looking at your workload and then how they're addressing or responding to these emerging trends. It is going to take time. This is a long-term effort, and it does take a lot of patience, as Kim and Carl both mentioned. Also consider using additional analysis methods to improve data collection and recommendations. We mentioned the psychological autopsy. Kim had mentioned that before. And so psychological autopsy, your fatality review process can identify, we see a cluster of suicide deaths in this particular population. Let's partner with our psychological autopsy specialist and have them do a deeper dive within these particular cases. And that can give you even more rich data. So really you have the national data and psychological autopsy. The mortality review process can help you identify and be more effective in funneling certain cases within the population, within the mortality review process. Also the VA's behavioral health autopsy program, our colleague, Dr. Stephanie Gamble, who is also a subject matter expert to support the development of the toolkit, is another example of some analysis that is really conducted to do a deeper dive into a smaller number of cases, but using the mortality review process to identify those. And then next is consider expanding review efforts to different population or fatality types. My experience with mortality review is another colleague who is an SME on the toolkit here out of an academic University of Colorado, was conducting all firearm deaths by suicide. And then he approached me and is like, wow, there are a large number of these firearm deaths who are veterans. Should we now take this out and look at that? And so when you start looking at one facet, there's another facet to consider. And so looking at other deaths, other populations, but then other jurisdictions have really looked at sudden unexplained deaths, right? So single vehicle accidents or suspicious drownings or other deaths that are not easily identifiable as suicide deaths, but really expanding that because we know that the identified suicide deaths are not all of the suicide deaths. So really after you get going, consider how you might expand to other types or different populations. And then finally, as we've talked about, it's very, very important to deliberately focus on reporting your conclusions to the community and providing those suggestions or those recommendations to an organization that has the ability to take actionable steps and make programs to develop that. And I think this is really where the value of the governor's challenge teams and the mayor's challenge teams to be able to partner with this, because those teams are actively engaged in program development to reduce suicide. The Mortality Review Committee can be an advisory committee to those governor challenge teams to say, here is something that you can actionably do. And again, it's really, really different community to community. Kim had mentioned that in Washington County, Oregon, evictions were a key risk factor, but in Humboldt County, California, they were not. There was no correlation between evictions. And so I think this is really key, is finding that focus on reporting your outcomes generally, whether to your legislators or your community, but also making actionable recommendations to departments of health, mental health, community engagement, and local suicide prevention coalitions. So at this point, I'd like to offer the opportunity for Carl and then Kim to provide their thoughts on these considerations. Carl?
Thanks, Dwayne. I want to go with number 5, the actual recommendations, because this brought us full circle. When we started this process, I wanted to know what programs work in Montana. I don't care what works in New York. And the data allowed us to figure that out. And so through the data, it was critical in our report that we couldn't just say, okay, here's the percentage. Here's what needs to be done. Here are examples of programs that could be implemented in Montana that are ease of implementation, cost of implementation, all that type of stuff. And so in our final report, we not only have the data, but we had specific examples of programs, whether it was the PACS Good Behavior Game for elementary, LOST teams, Zero Suicide for primary care, SOS school-based for middle and high schools, QPR for clergy and first responders, mental health first aid for librarians. We really, none of that would have happened if we didn't have the data, and it allowed us to kind of complete the circle as far as what we started off doing.
I don't have a lot to add except for just the reminder for number 4. If you do have, this particular came up in Washington County when we had Jehovah's Witnesses death, and we didn't feel that voice was represented at the table. So, we went and got an elder. Just if there is something unique about a person's life that you don't have a voice for at the table, try and do your best to get someone from that community to help. And that's all I have for that.
Thank you so much, Dwayne, Carl, and Kim. I think that it was a really robust discussion. We have a couple of minutes for questions, and I did also see, Dr. Berman, you've got your hand raised. I don't think we have the ability for unmuting at this time, but if you're able to type in wait a second. Dwayne, please jump in and set me right here.
Thank you. You're reinforcing my laziness to actually type out my question. I could have totally done that. I actually had a question more for the national team. So Andrea, maybe you're the best person to respond. But I wanted to know, Carl, I came out to visit in Montana, and you have helped us so much with so much of your paperwork and getting started. And Kim Rep came out to LA to really train us. I think one of the biggest challenges that folks have had before us and are probably going to have after us is really just getting through the red tape to be able to share data. Folks have done that through legislation, through MOUs, all kinds of different ways. And I love, Carl, that you've highlighted this notion of let's not reinvent the wheel. There are already things that are out there that have been approved. My question really is there anything that VA at the national level has endorsed? Because we know that one VA is one VA is one VA, and we could come and say there's precedence at 12, 15, 20, 50 VAs. But every privacy officer wants to review, you know, the MOU, even if it was copied and pasted from something that already existed and everyone sees it from a different lens. And I'm wondering if there are templates that VA has endorsed nationally that we could bring back to our counties and states that can ease the process for us.
Yeah, that's a great question, Dr. Berman. Thanks so much for raising. I'll do my best and really can only say not yet. Unfortunately, I think that we are really grateful for you all in that you are really blazing the path for some of this work that can inform that advocacy that we can do at the national level. So all of the work, all of the feedback we hear from these teams will help to influence those broader conversations that we can have at the national level. I don't know if Carl or Dr. Rep, you had anything you wanted to add to that.
I really didn't. I just want to emphasize that some of the hard work's already been done. So use what's out there. It may have to be adapted to your state or to the VA system a little bit, but it's out there. So use it.
Thanks so much, Carl. We did also have a lot of really great back and forth in the Q&A, knowing that we have a couple more minutes to thank you so much to our presenters for answering some of these sort of offline, but I did want to touch on again, thinking back to how do we operationalize this concept? And there was a really great question that came in. Carl, if you're able to expand a little bit on the Montana specific question. The question that came in was, do I understand correctly that Montana reviews all 300 plus deaths each year? If so, how do you get through them and how much time do you spend meeting?
Well, it's a lot easier now. Now we have the National Violent Death Reporting System. Basically, yes, we review all of them, and it goes out through two different sources. All the death certificates come to me. I collect individual on every death certificate has about 18 to 20 different data points so that I have a running total, and it's about as close to real time as you can get. But one of the systems that all the coroners, and this is something that we collaborated with the Department of Justice on, is that there's a centralized intake, basically, that for all death information, every coroner's report, any medical records, all is entered into a centralized system by a coroner, which automatically then goes to our VRDS folks. And so they're able to do it on a daily basis. I can't tell you how long it takes them to go through. I know I only spend a couple hours a week collecting the data and getting resources out. But we now have that centralized intake, which has made it streamlined the information much easier.
That's great. And I did see, I know we have only got a couple of minutes left. Wayne mentioned the webinar is going to just, end us right there. So I did want to touch on, I loved this question that came in. How many data points are being collected with regards to death investigation? How far back does the investigation go? For thinking of, back to when you were just starting these efforts, for Carl and Dr. Rep, what can you advise for these groups as they're just starting up?
So from when we get our vital stats data, there is probably around 300 variables just from vital stats about that are related to the death certificate. In our surveillance system, we collect another 60 or 70 for each of the death. So we use all those pieces of information.
The only thing I'll add is as far as health records and how far back we went, we usually requested 3 years of information. And sometimes they would give that, or sometimes I'd get 20 years. So I had lots of different people that give you different stuff. So.
Yeah, I guess I should say that too. If it's a medical record review and we're looking at chronic disease, it's going to, we will go all through the entire medical record. The death investigators will before we get there. We started our program in 2014, so we have data from 2014 on that we use.
Really helpful. Thank you so much. I think some of these really the nuts and bolts of how do we get there will be so critical. And we're so grateful for your expertise, Carl and Kim, in this area. And just want to highlight that we will have these subject matter experts available throughout this process so that as questions continue to come up, we will be able to consult with these wonderful folks here. As we wrap up, thank you so much. Dwayne, I will turn it over to you to wrap us up. But again, thank you all for joining us, and thank you so much to Kim and Carl as well.
Yes, thank you again, obviously, to the panelists, for our partners both at VA and SAMHSA for supporting this effort. It truly is a part of the public health approach. And so for those of you who are attending, who are part of the Suicide Mortality Review process, this is just the beginning, as Andrea mentioned. The ongoing technical assistance is always available, either through the SMVF TA Center website. We do have monthly email roundups, but also your TA Center state liaison and your VA program manager can also provide that technical assistance. When the webinar ends, a pop-up will come up and it will be an opportunity for you to engage in a survey. Let us know what you thought about this. Also, again, always constant improvement. But then at the end of that survey, there is a certificate that you would be able to download, and you would be able to put your name in to indicate if you need to be able to provide proof to your colleagues, your employer, that you attended this, that you will be able to have a certificate of attendance for this webinar. And again, as always, you can reach out to the SMVF TA Center at smvftaCenter@prainc.com. And we thank you so much and look forward to engaging in this process with you. Have a good day.
Bye, everyone. Thanks so much.